Infective endocarditis, or IE, is the inflammation of the endocardium resulting from a pathogenic infection. The endocardium is the smooth inner lining of the heart covering the heart valves. Endocardial lining can be injured in certain conditions, such as valvular heart disease, congenital heart disease like ventricular septal defects, certain types of prosthetic valves, and previous episodes of IE. Endothelium injury exposes the collagen and tissue factor, which causes platelet aggregation and fibrin mesh formation, resulting in small blood clots, so-called non-bacterial thrombotic endocarditis, or NBTE, which do not contain any bacteria. Every day, bacteria can enter the bloodstream from daily activities like brushing teeth or from the lungs and gut. Usually, the immune system wipes out these bacteria without trouble. But sometimes, bacteria can remain in the bloodstream and attach to the blood clots of NBTE, causing an infection called vegetation. Some bacteria have molecules called adhesins on their surface that help them stick to heart valves and each other. The avascular valve tissue, platelets, and fibrin mesh also help to protect pathogens from host defense mechanisms and allow them to grow into larger colonies. The left side of the heart, particularly the mitral valve, is typically more affected in IE. The next one is the aortic valve, and less frequently the tricuspid valve on the right side, especially in people who inject drugs. Acute IE develops suddenly and presents with rapid progression, high fevers, rigors, sepsis, and changing heart murmurs. Embolic events are common, and cardiac or renal failure may develop rapidly. It is life-threatening and requires prompt medical attention. In contrast, subacute IE is more common in patients with congenital or valvular heart disease. Initially, it tends to present with less severe symptoms like long-standing constitutional symptoms such as fever, fatigue, and malaise, and progresses gradually. Most cases of subacute IE are caused by penicillin-sensitive Streptococcus viridans, while Staphylococcus aureus is the leading cause of acute IE. Staph aureus is famous for high virulence and typically hangs out on the skin. It can sneak into the bloodstream through skin infections, abscesses, or even intravenous or central lines. It can affect both healthy or already damaged heart valves. They can grow very fast and form abscess and rapidly damage the valves, resulting in severe symptoms. Although they usually attack mitral valve, tricuspid valve involvement is more common in people who inject drugs. Viridans group Streptococcus includes Strep mitis and Strep sanguis. In contrast to Staph aureus, they are low virulent bacteria. They are commonly found in the mouth. They can enter into the bloodstream during everyday activities like chewing, toothbrushing, or dental procedures. These bacteria typically attack already damaged heart valves and form small vegetations. Since they have low virulence, they usually don't cause valve destruction. Less frequent organisms include Enterococci and Strep galolyticus, also known as Strep bovis. Enterococci usually stay in the urogenital tracts, but they can sneak into the bloodstream during urogenital procedures or prolonged catheterization. Strep galolyticus are also part of normal flora in the guts. In conditions like colon cancer or inflammatory bowel disease, they are more likely to enter into the bloodstream. So, if the patient is diagnosed with endocarditis caused by Strep galolyticus, it's recommended to undergo colonoscopy. Patients with prosthetic heart valves are at risk of infection from Staph epidermidis. They are normally found on the skin. They can sneak into the bloodstream through central venous catheters or long-term IV lines. Less commonly, infective endocarditis is caused by Haemophilus. They're a group of gram-negative bacilli which include Haemophilus, Aggregatibacter, Cardiobacterium, Eikenella, and Kingella that usually live in the oropharyngeal cavity. They are slow-growing bacilli and blood culture may return sterile. Q fever endocarditis, caused by Coxiella burnetii, often affects individuals with a history of contact with farm animals. These bacteria need host cells to survive and multiply and do not grow on typical culture media. It can lead to sterile blood cultures, making it tough to detect without specialized tests. Lastly, fungi like Candida and Aspergillus can also cause endocarditis, especially in patients with weakened immune systems or those with long-term indwelling intravenous catheters. Clinical symptoms of IE stem from damaged endocardium and heart valve, septic embolism, and immune reactions. The immune system responds to the microbial vegetation by releasing antibodies, cytokines, reactive oxygen species, and proteases to fight the infection. However, this immune response can also cause inflammation and damage to the valve and perivalvular tissues. As a result of valve tissue distortion, cus perforation, or rupture of the chordae tendineae, it can lead to valve regurgitation. When the mitral valve and surrounding tissues are affected, it leads to mitral regurgitation, characterized by a pansystolic murmur. During ventricular contraction, the mitral valve cannot fully close and allows blood to flow back into the left atrium. This can result in pulmonary edema due to increased pressure in the lungs. Also, the stroke volume and cardiac output is decreased. This can lead to hypotension and cardiogenic shock. Damaged aortic valve also causes aortic regurgitation, producing a decrescendo early diastolic murmur. Highly virulent pathogens may lead to abscess formation around the valve or in the surrounding tissues, causing complications such as aortitis or aortic root abscess. For patients with prosthetic heart valves, damage to the surrounding tissues can cause the valve to separate from the endocardium, known as prosthetic valve dehiscence, resulting in leakage around the valve. Sometimes, turbulent blood flow can break off small pieces of microbial vegetation, releasing them into the bloodstream as septic emboli. The antigen-antibody complex or immune complex can also be carried by the blood and deposited on various tissues throughout the body. The embolic complications can arise depending on where the emboli travel. When they originate from the left side of the heart, they can enter and block the coronary artery, causing acute myocardial infarction, or block major arteries, leading to ischemic stroke or acute limb ischemia. The artery around the septic emboli may become weak and dilate, resulting in a mycotic aneurysm. This can also cause intracranial hemorrhages or brain abscesses. They can also lodge in the nail beds, leading to splinter hemorrhages or macules and papules on the palms and soles, known as Janeway lesions. These skin lesions are painless. They can travel to the spleen and kidney, causing infarct or abscess in respective organs. In cases involving the tricuspid valve, they can travel to the lungs, potentially causing pulmonary embolism and lung abscesses. Additionally, deposition of immune complexes triggers immunological reactions, which cause inflammation and tissue destruction around the site of deposition. On the hands and feet, they can result in swelling, redness, and pain, known as Osler's nodes. These painful lesions are typically found on the fingers, toes, palms, and soles. They may also deposit on the retina, leading to vision impairment, which can be observed as Roth's spots on fundoscopy. These immune complexes may deposit in the glomerular capillary and cause glomerulonephritis, which can be manifested by proteinuria and hematuria. Additionally, there may be an elevation in rheumatoid factor, although the exact mechanism is not fully understood. Getting blood cultures is crucial for diagnosing IE and guiding antibiotic treatment. 3 sets of blood cultures should be drawn at 30-minute intervals before initiation of antibiotics. Common pathogens should be detected from 2 of the 3 blood cultures. After initiating treatment, blood cultures are sometimes repeated after 48 to 72 hours to assess the response to therapy and adjust treatment. Persistent positive blood cultures after initial treatment may indicate uncontrolled infection and is associated with a worse prognosis. Blood cultures are like tracing the footprints of invading pathogens. However, it's important to note that sometimes blood cultures may come back negative. Another significant clue for diagnosing IE is evidence of endocardial involvement. These two clues constitute the major criteria in diagnosing IE, known as modified Duke's criteria. Clues for endocardial involvement can be detected by a transesophageal echocardiogram, or TEE, and a transthoracic echocardiogram, or TTE. TTE is the first test in most patients, but there are specific cases where a TE is preferred. These include if the patient has a prosthetic valve that could be infected, if there is concern for complications like perivalvular abscess, or if clinical suspicion points strongly towards endocarditis. Both imaging methods will help to detect an intracardiac vegetation on a valve or implanted material, such as an intracardiac device, or new valvular regurgitation. However, it's important to note that hearing a changing or worsening murmur during auscultation isn't enough to confirm endocarditis. In addition to the major clues, there are 5 smaller hints that can help to diagnose IE. Firstly, patients may have predisposing heart conditions or a history of injection drug use. Fever is another minor hint, triggered by the body's immune response to the presence of bacteremia. The spread of septic emboli from the intracardiac vegetation can give some clues, including major arterial emboli, mycotic aneurysms, intracranial hemorrhage, septic pulmonary infarcts, or painless Janeway lesions. Additionally, the deposition of immune complexes in tissues can manifest as Roth's spots, glomerulonephritis, painful osseous nodes, or positive rheumatoid factor. If a blood culture comes back positive, but it does not fulfill the major criteria, it is considered minor criteria. Minor clues, when combined with other clinical findings, can further support the diagnosis of IE. To confirm the diagnosis, 2 major criteria or 1 major and 3 minor criteria must be present. Alternatively, all 5 minor criteria suffice for a definite diagnosis. If there's only 1 major and 1 minor criterion, or just 3 minor criteria, IE is considered a possibility. Clinical signs and symptoms, along with imaging findings, may strongly suggest IE. In such cases, waiting for culture results may delay treatment, allowing the infection to progress and cause more severe complications. Prompt initiation of antibiotic therapy is crucial to prevent further complications, such as heart valve damage, embolism, and systemic infections. Empirical antibiotic therapy often involves broad-spectrum antibiotics that cover a wide range of potential pathogens commonly associated with IE. Empirical antibiotic therapy for native valve endocarditis and late prosthetic valve endocarditis should cover Staphylococcus, Streptococcus, and Enterococcus. One regimen to consider is ampicillin in combination with ceftriaxone and gentamicin. Ampicillin targets Streptococcus species commonly involved in native valve endocarditis. Ceftriaxone provides broad coverage against various bacteria, including Streptococcus species. Gentamicin is added to enhance bacterial killing, especially for Enterococci and certain Staphylococci strains. For early prosthetic valve endocarditis or healthcare-associated IE, the regimen should cover methicillin-resistant Staphylococcus, Enterococcus, and non-Haeckig gram-negative pathogens. One option is vancomycin combined with gentamicin and rifampin. Vancomycin is effective against common pathogens in these conditions, like methicillin-resistant Staphylococcus aureus and coagulase-negative Staphylococcus. Rifampin is often used alongside other antibiotics to penetrate biofilms and eliminate staphylococcal infections, particularly in cases involving prosthetic devices. Once the pathogen is identified, antibiotic treatment should be adjusted based on its antimicrobial susceptibility pattern. Besides antibiotics, surgery is often necessary in various situations. When an infection damages heart valves, causing significant regurgitation or stenosis, and sometimes leading to severe heart failure unresponsive to medical treatment, valve repair or replacement becomes necessary. The antibiotics do not always work in IE. If antibiotics fail to control the infection effectively, removing infected tissues or draining abscesses may be required. Fungal infections of heart valves are hard to treat with medical therapy alone, and surgical intervention can sometimes improve the outcomes. Infections involving prosthetic heart valves, challenging to manage with antibiotics due to biofilms, may require replacing the infected valve. Additionally, large vegetations on heart valves increase the risk of embolisms, potentially causing stroke or organ damage. Surgical removal is sometimes necessary for preventing embolic complications. Antibiotic prophylaxis is advised for patients at high risk of IE undergoing specific dental procedures that pose a risk of bacterial entry into the bloodstream. These procedures include dental extractions, oral surgeries like periodontal surgery or implant surgery, and dental procedures involving manipulation of the gums or tooth roots, such as root canal procedures. The primary aim of prophylactic antibiotics is to target oral Streptococcus, the bacteria commonly associated with IE. Typically, a single dose of 2 grams of amoxicillin is administered 30 minutes before the dental procedure. For patients allergic to penicillin, azithromycin can be used as an alternative.